Hello and welcome to the Pediatric Network. Today we're going to be chatting with Dr. William Tortoriello, who is a chiropractor out of Chicago, Illinois in the United States. Now we're talking to Doc because he is an instructor of DNS, which is Dynamic Neuromuscular Stabilization. This is an approach to patients and in particular, a particular approach to pediatrics. So we're going to be talking about what DNS is, where it comes from, what your general DNS approach would be to a pediatric patient. So without further ado, Dr. William Tortoriello. Hello and welcome to the Pediatric Network. My name is Mike Marinas. I'm your chiropractor and host here for all content pediatric related. And today I am chatting with Dr. William Tortoriello. How are you doing, Doc?
How you doing, Mike? It's great to be here. I appreciate you having me.
We have tried to organize this for the longest time.
Yeah. Well, across the world sometimes makes it a little difficult, particularly with certain things going on.
Absolutely. Just one or two minor things that seem to be inconveniencing the whole world at the moment. But here we are. And the reason we're here is I'm really keen to speak to you about DNS and pediatric DNS, Dynamic Neuromuscular Stabilization. A lot of people, I find from just my sort of walking through life, a lot of people have no idea that DNS is even a thing. Some people have heard about DNS and they kind of go, we're just moving people around, and then other people quite knowledgeable into it. So I'd like to start off with you, if I can, just give us a background. What is DNS?
So, number one, you passed the first test. You could say what DNS actually stands for, Dynamic Neuromuscular Stabilization. So DNS is a principled approach to physical medicine and physical therapy and rehab. It is based on the tenets of developmental kinesiology, which we're going to get into, but basically developmental kinesiology are the tenets of spontaneous movement of the infant over that first 16 to 18 months of life. We use the principles established in that first 16 to 18 months of life as the objective framework and basis for all future movement and all physical therapy and rehabilitation. Now, one thing I always try to point out kind of some of the questions that I had taking the courses along the way, or things that were confusing for me, or even, popular things that people ask me about some things that are confusing, at least. And one is the concept of things need to be perfect and ideal for DNS, that every exercise, every posture, every movement has to be perfect in order for it to be good. And I can tell you right now that that is not exactly true. We have a framework, we have a reference that we have in our heads, but of course, things don't need to move perfectly in order for them to be good or useful.
Yeah, I like that. Because, a lot of the time people subscribe to it's got to be perfect, but in this thing, it's got to be more workable than anything else.
Oh, yeah.
So where does DNS come from? Where are the roots of this idea?
So DNS, the originator or the founder of DNS is a doc named Pavel Kolaj. He is the director of rehab and for the University Model Hospital in the Czech Republic, which means I have a little list that I usually go to because it's everything. I don't know if you're seeing what I'm seeing, but Director of Rehab Department for University Hospital Model, which means that he's following and overseeing the entire rehab unit for outpatient, inpatient, adults and children, the pain management unit, the spinal unit, the School of Physiology, and the entire Department of Sports Medicine. Let me get back to where we were. He was the personal physician to the Czech Republic's Prime Minister Václav Havel. He's the team physician for all of their national teams, including the tennis team, the hockey team, all of that stuff. Now DNS, again, is based on this concept and the framework of developmental kinesiology, which is how infants spontaneously move over that first year of life. And he learned this kind of thing, and he learned this approach from basically his mentors in the Prague School of Rehabilitation, which are guys like Vladimir Janda, Karel Levitt, and specifically Václav Vojta. These are three of the founders and fathers of manual medicine that originated in the Prague School. Václav Vojta in particular developed his Vojta approach to pediatrics, which is what the fundamentals of DNS are really based on. A lot of the DNS instructors and DNS PTs are actually Vojta trained therapists as well.
All right. So it comes from there. Now, how does one go about, because we're going to explore it a little bit, but just to give a bit of background, how does one then get involved in DNS? How does one become a student, and what kind of courses are on offer?
Okay, so if you go to the DNS website, which is, I'm sure you'll link to it at some point, but it's rehabps.com, they will show a list of courses. Now, there's one track of courses that are really more geared to healthcare professionals, physicians, PTs, doctors. These are your clinical A through C courses. They have just obviously a little bit more content, go into a little bit more depth through their 3 days rather than 2-day courses. Then you have a second track, which is called the exercise track. These are courses that are more geared towards athletic trainers, massage therapists, performance coaches, things like that. Now, having said that, physicians take those exercise courses all the time, and they're encouraged to, because number one, if you do just want to get more of an introduction, because they are only 2-day courses versus 3-day courses, they can show you some of the basics. If you obviously want to get a little bit more in depth, you go for the clinical courses. The third track is the pediatric courses. There's a completely separate third track, which are pediatric courses. Obviously, as the name implies, they basically only go through all of the details of the pediatric assessment and treatment. They're actually 4-day courses, and there's 3 of them. There's pediatric 1, 2, 3, or A through C, I don't remember. Now, separate from those 3 tracks, there are specialized courses. There can be a course devoted to foot and gait. There can be a course devoted to visceral mobilization. There can be a course that myself and one of the other instructors, Robert Lardner, have created called integrative assessment. There's courses on scoliosis. Those are individual, typically 2-day courses that you can also take as well, separate from the tracks.
Okay, so there's a lot of scope inside there. Pediatric being one track that you can follow down. So we're going to drill down a little bit into DNS in pediatrics, and I think I'm going to start off with, why is it so important to understand that those movement patterns, those innate built-in movement patterns that are there within those first 18 months? What do they do for the infant? Why are they there? Why do we need to know about them?
Well, in one sense, I like the idea that you already said innate programs, because that's exactly what they are. They are hardwired genetic programs located in the subcortex. These are not something that the child learns to do. These are genetically hardwired programs. You could almost think of them like whole body global reflexes that they do not have voluntary control over. This also means that they're universal. It's not like babies in South Africa develop any differently than babies in Chicago or babies in Australia. These were all humans. We all evolved in the same manner, and we all have these programs located in the subcortex. So that's one thing I like, and that really appealed to me, was the universality of this. If you want a truly objective framework to identify what is better or worse about a particular pattern of stabilization or movement, this truly is the only thing. I say that confidently. There's no other way to measure better or worse besides the framework and the principles given to you in these developmental milestones that occur over those first 16 to 18 months. Now, separate from that, another reason why they're important is because movement, particularly over the first year, children, obviously babies can't communicate with you. They can't tell you if something is painful. They can't tell you if something is difficult to do. They can't tell you if something is wrong. They can't tell you if they have cerebral palsy. So movement and posture is literally a mirror into the child's central nervous system. It is a direct mirror into how that child is functioning. I think of it no more different than a reflex, a tonic reflex. Tapping somebody's knee is a mirror into how somebody's nervous system is functioning. How they're moving and stabilizing, particularly an infant, is a mirror into how they're moving and stabilizing. And I think it's a very sensitive mirror. So when I see children and I assess them, I am looking at how they're moving and stabilizing, and I'm measuring it against the developmental kinesiological framework that I have in my head. And insofar as what I'm seeing is veering from that framework, I start to think a little bit. I just put a flag down and say, okay, that's a little different. That's a little different. Of course, veering from the perfect framework doesn't necessarily mean anything in and of itself, but it's a little something to consider. And when you start to pile on all these other things as you build your assessment, then you start to consider things a little bit more important. Finally, what I would say on more of a functional level is how you move and stabilize later on in life the foundation is being built in the first 16 to 18 months. So for example, the common thing that, pediatricians, and I have nothing against pediatricians at all, everybody should utilize a pediatrician, but if a pediatrician tells a mom that their child doesn't need to crawl because, the pediatrician's child doesn't need to crawl or never crawled, it's not a big deal. They don't need to. You could skip a milestone. Not a big deal. What I tell the mom and what I personally think is that in one sense, you're right. It's not a big deal. You don't have to go to the emergency room. In another sense, what's the utility of crawling? The utility of crawling is to get sensory input through your hand that provides feedback into the brain, which allows you to learn how to stabilize and control the upper quarter, for example. Now, if you just totally skip that step and move on to something else, you're lacking in experience of stabilization of your shoulder. And maybe that means that when you're 12, 13, or 25 or 40, you have a significant winging scapula on that side, and that shoulder always just seems to give you some problems. And you're not the relief pitcher for the Chicago Cubs, but it always seems to give you a problem and you don't necessarily know why. Now, I'm not saying it's 100% because you never crawled when you were 9 months old, but I'm saying this is one of the reasons why it's important to hit these milestones.
It's going to be in there. I remember having it explained, that kind of concept being explained to me years ago, where they said it's like doing a year of a physics class, but missing your first 2 months. You can do the rest, but you're always going to come up against concepts that you never were taught. And then you have to work so much harder to get that part to work. You can get it to work, but it's so much harder to work because you don't have it as a foundation to be able to build back on.
That's a really nice analogy. I might steal that analogy. You might see it in the course. Go, that sounds familiar.
Good.
Say it was mine the whole time.
It is exactly that, and it's wonderful to hear it from you, because it solidifies in my mind the way I've been thinking about it. So that's wonderful to hear it from someone who's in a position of being a DNS instructor, to actually say, and I love the way that you put it, because it's not an emergency room idea. It's not like you end up with something that you can go, this exactly caused that. But you can say, look, we know that if those things don't happen initially, the chances, and everything is worked out on ratio, right? So the chances later that you are going to have a problem are much bigger. And if you do, the chances we could have minimized that problem for you in the beginning are so much higher. And then we just work in that space. We can own that space.
Exactly. And then, that obviously, I mentioned it, but it's like when the typical kind of pediatrician gives the watch and wait prescription, and the watch and wait prescription can be 3 months. The baby goes in for the 3-month or the 4-month checkup and then doesn't come back till the 6th or 7th month checkup. If something was abnormal during that the 3rd and 4th month, that I pick up on, I don't necessarily want to wait 3 months to let it solidify if it was something significant. I would much rather, like you said, try to nip it right in the bud, get after it a little bit. Doesn't mean I have to see you 5 times a week for the next 6 weeks, but we can try to do some mild things to try to see if and when. It's almost part of the test. It's, well, we're going to do some handling, maybe a little bit of an active exercise, and if things progress and move forward, perfect. If they don't, well, now we're going to know immediately that something is actually wrong and what we saw was significant. But if we're just watching and waiting for everything, then, you know, there's I don't understand the concept.
Yeah, and I think COVID is an interesting sort of version of that, because we're going to see so many of these now, because it's forced watch and wait. I mean, I read a paper a couple of weeks ago now, somewhere around there, where they were already talking about missed hip dysplasia diagnoses, and now because you've missed that magical window, and I can see that happening with plagiocephalus, I can see that happening with developmental milestones. And the problem is, and I don't know, you're welcome to disagree with me here, because I'm just kind of spitballing this idea, but I know that little kids compensate. They compensate so fast, so that when you see them again in that 4 months, you might not pick up 1 or 2 of the things that they've actually glossed over, unless your history is really good. And then they've already decided that they can compensate for that. And then you look at their movement pattern. And I suppose if you're not someone that's as wonderful and trained up as yourself, you might miss the fact that they are, you know, they're compensating, or they're trying to get away from something. And I imagine that happening.
Oh yeah. Yeah, no, I mean, that's, I agree. I mean, that's perfectly said. And that's kind of what drove me to the pediatric side. Not that I see adults. That's primarily what my office is adults. But obviously I see infants as well. But when I took my first DNS course after I graduated chiropractic school in 2006. I took my first DNS course in 2007, and Pavel Kolaj was there, and he demonstrated an assessment and treatment on an infant who was screaming the entire time, crying, and I was horrified, and I said, who in the hell would ever want to do this? This is, oh my God, somebody call the police. You know, this was horrifying. And obviously 5 years later, the kids are screaming, and I could care less. You know, I'm in the seminar doing exactly what he did, because there's an understanding. But it's that I thought about it, and I said, it almost paralyzes you a little bit, because I think, I'm wasting my time with the adults. These things are ingrained in them. I can't really make a change with them. If I could have only gotten them when they were babies, I could have really done something. And then I thought, well, I can get to them when they're babies. They're offering me this education, so let's do it. So that's kind of how I personally got into it. I thought if I could just get to them when they were babies, then I could really try to get after it.
Yeah, I mean, it reminds me so much of the thought process of, you know, when you're an adult, your structure dictates your function, you know, but when you're an infant, your function ends up dictating your structure. And
100%.
If you can just get in there in the beginning, and you can just get those correct movement patterns, which is really what sparks my enthusiasm for something like DNS, is to get in and get the correct movement patterns going. They can then go off and play sports and do all sorts of things, happy in the knowledge that they're not compensating for things, they're not underlyingly just making things worse just by having these incorrect movement patterns as they go. And then, as you say, you end up with someone who just has this flared out shoulder, but it becomes a huge part of their life, big part of it messes with their job, messes with their, you know, their well-being, you know.
Mm-hmm. Mm-hmm. And, you know, you said something that might, I don't know if it'll strike a chord with people listening to this, but I can imagine it might strike a chord with other people. The idea, first, the concept that there is even something called a compensation pattern, and that there's something called, you know, an ideal pattern. You know, I think you're probably aware that there are people that say there's no such thing as compensation, no such thing as ideal. And, you know, with that being said, I understand somewhat where they're coming from, but when your posture or your movement resembles that of a child with spastic tetraplegia, then I would say, I think we can agree it's not a good posture. It's not a good movement pattern to use. Now, obviously, that is a far end of the spectrum, but when you see some significant internal rotation elevation of a shoulder, you see slight ulnar deviation in the wrist when they attempt to stabilize, you can say that that is on the way to going the full spastic route of a cerebral palsy child. You know, that's how we're doing it. And then I go back. It's not an emergency room situation, but it's something.
Yeah. Yeah, no, I think you bring up some really, really important points, and I have heard that argument to the point that there's no bad posture. There are just postures, you know. And I suppose, but I suppose I'm always in the position of, I try not to put my flag on a mountain, you know. I'm always in the position of, I think the evidence points me this way, my personal preference points me this way, and I'm happy to be proved. You just have to really prove it properly. You know, if you're gonna come with it. But I think that's really, really interesting in terms of those compensation patterns, yes or no. Let's talk about milestones inside this, because there are trajectories that the children are going to take. We know that there is a normal trajectory or a common trajectory the children take, and within that trajectory there are things that we'd like to have happen within time frames, and I've heard them being spoken about as almost like there's a golden time frame for a certain milestone to happen. Now, why are these important that these happen and they happen correctly?
Well, you know, I mean, we've talked about it a bit already. They're foundational, first of all. So, for example, newborns. Newborn, whether they're lying on their back or they're lying on their belly, have absolutely no ability to control or stabilize their spine. None. They're just essentially breathing in and out. Obviously, limbs are moving, their head is moving, but they have no ability to control or stabilize, which also says that they have no ability to control any movement, to perform any isolated movement. You know, this is also described as holistic movement or holokinetic movement, where if a finger moves, the entire body is going to move. They can't isolate any movement. Now, over the first 3 months in supine, for example, at about 3 months, the child begins to coordinate the abdominal wall musculature with the diaphragm breathing. This coordination involves a little bit of pulling down of the rib cage into a more neutral position that places the diaphragm and the pelvic diaphragm or the pelvic floor into a more parallel position. And that allows for the introduction and the creation of a slight amount of intra-abdominal pressure. That intra-abdominal pressure within the abdominal cavity is the first primary source of stability for the lumbar spine and pelvis. And that allows the child to perform some differentiated controlled movement. First of all, it can stabilize itself in the midline, in the sagittal plane. It's not just rocking back and forth uncontrolled. Once it's in the midline, it can hold its head in the midline, and it can lift both hips and knees and lower extremities to the about 90 degrees of hip flexion, 90 degrees of knee flexion, ankle dorsiflexion. And babies just will rest there in that position and breathe in and out. Why is it important? Well, it's important because on my end, because it tells me that the child is doing what it ought to be doing. The nervous system is functioning adequately, because by 3 months, we know typically most children ought to be able to do this. If I didn't see it, I would start to look at some other things. From the baby's perspective, it's important because this primary source of stabilization through the creation of intra-abdominal pressure using diaphragmatic breathing and a slight abdominal brace, that is the #1 source of stability for the lumbar spine and pelvis. That is going to be used throughout its entire life to primarily stabilize. It's the first thing that goes when you look at somebody in chronic low back pain or acute low back pain and they do the research. That primary ability to change the position of the rib cage to create the intra-abdominal pressure and engage with all of the musculature, a chain of muscles, not just transverse abdominis, that's the first thing that gets inhibited and goes. So I can extend that and say, okay, so at 3 months, between 3 and 4.5 months, they really develop this. They're doing it a lot. They're getting experience with it. So by 4.5 months, they have solidified sagittal plane stabilization in supine. And again, from my perspective, I'm looking at the 4.5-month-old to see that they can do it. And from the 4.5-month-old perspective, I want to be able to really be able to control this, because I'm going to use it for all of the other things that I'm going to do over the next year.
Yeah.
So that's, and obviously having an adequate understanding of these milestones is important from supine and prone.
Absolutely, because as you say, you need these things to build the next story and the next one. And if you don't know what you've missed before, you don't quite know where you're sitting and and maybe why your next milestone's not coming. Good to be able to know what the ones before are, to be able to look back and go, well, we've missed this, we've missed that.
You say that, and that's kind of, when you assess the infant, if you really feel that something is going on, you call them, you have an idea of their calendar age or their chronological age, but you also have an idea of what their developmental age is. The child might be 9 months old, but technically it's only 6 months old in supine, because it can't do these certain things. So like you said, that's where we would start with the training, is at the 6-month position. Because there's no point in starting at the 9-month position if they can't even do the 6-month.
Yeah. So, Doc, I want to kind of finish by asking you, if someone, just to give a basic idea, let's say, and you're welcome to change the vignette if you like. But
I probably will.
I was just thinking a baby that comes in, and let's say mom says, baby's lying down, having trouble with the left side, let's say, not moving to the left side, very right side dominant. Just take me through your thinking a little bit, just so we can get an idea of that.
Okay, that perfect example of the child that, maybe the child 6 months old always had a fixed predilection, which means that the child preferred to have its head turned to the right. It wasn't necessarily torticollis, but it was fixed. It lasted longer than 6 weeks. So it made it difficult to turn to the left. By 6 months old, babies ought to be turning or from supine to prone in both directions. And as you said, this baby's turning to the right, but not necessarily to the left. First, you go through the assessment. A DNS assessment consists of 3 things. Observation of spontaneous movement, which I just described.
Yeah.
I watch the babies move throughout everything, and I note any problems that I see. Then we have analysis of primitive reflexes, which are just a bunch of primitive reflexes that you're checking. And then we have analysis of something called postural reactions. These are according to Voita. Some of them are more standardized, like a traction test, where the baby's lying in supine, you take their hands and you lift them up. Looks like they're doing a little crunch or a little sit-up. That's a postural reaction. So you put them through the observation of spontaneous movement, analysis of primitive reflexes, and analysis of postural reactions, and you get an idea. All 3 of those things gives you an idea of where this baby is, how this baby's functioning. Now, with this child who's having a difficult time turning to the left, rotating to the head to the left, I would go back and I just think through all the developmental milestones of what is required in order to turn the head to the left, what's required to turn the body to the left. And I can begin with the basic supine 4.5-month position, initiating head turning to the left. So that involves some handling on my part. I position the child. I place my hands on particular areas of the child, usually to reinforce support points on them, to help them and give them experience with the position in the best way. Obviously, I'm trying to engage them with toys and with mom to turn their head to the left, anything I can to get them to do what I want them to do. And then there's and then you go through more of the positions from 4.5-month supine. 5-month supine is actually turning on to the left side. So now I can prop them on their left side, place them into the position, use my hands to guide the movement, apply resistance when I want to, apply pressure in other instances. And, I'm just trying to reinvigorate all of the patterns that seem to be missing or just seem to be lacking in the infant that is not allowing it to turn its head to the left and rotate to the left. And then after I do it, I show the parents how to do it, because according to DNS and Voita, this is something that requires some frequency and consistency. Yeah. With something severe and significant, they talk about short bouts of treatment for maybe 6 to 8 to 10 minutes, 3 to 4 times a day, performed by the parents. Now, it sounds like a lot, but if you have a child with cerebral palsy or hip dysplasia, or not that hip dysplasia is that significant, but on that spectrum, you will be, first of all, you're already going to be going to PT, OT, developmental, everything. So you're used to doing these things, and you will do it for your child. So you have to teach the parents how to do it. They go home and they do it. A week later, 2 weeks later, they come back, we review things, I show them an extra step, and they go home and they do it again. That's kind of what it looks like.
Wonderful. Wonderful. Thank you very much. Just giving us that nice run through, because sometimes, you can talk through things theoretically, but to be able to go, this is what the thought process would be through, gives a nice idea of what exactly is going on when you go through a DNS set of thinking when it comes to a child. Doc, thank you so much for your time. I'm definitely going to have you back on again.
Thank you so much, Mike. I really, really appreciate it. I'm glad we were able to do it. And keep up the good work. You're doing an amazing job.
Thank you very, very much. I really, really appreciate that. Dr. William, we are going to be putting links to the website we were talking about. I'm also going to link to, if it's all right with you, Doc, your YouTube channel.
Of course.
Which is fantastic, because you really do get a nice sense of DNS from that. So again, I thank you very, very much for your time.
Thank you very much.